Well, good afternoon, everybody out there in SADS Facebook Live land, or good evening in Israel with my dear friend, Dr. Sami Viskin, or good morning, early morning down under, wherever you are and wherever you're joining us. Thanks for joining us for the 32nd SAD Facebook Live. I can't believe this is our 32nd episode. And I've been looking forward to this one for a long time with Dr. Viskin. Sami, welcome to the SADS Facebook Live.
Thank you, Mike. Thank you for having me.
You know, on behalf of Alice Laura, the CEO of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, we're delighted that all of you have chosen to join us. This is a pretty significant Facebook Live. Of our 32nd episodes, this is our first one with our President of the United States and his wife, our First Lady of the United States, learning that they are SARS-CoV-2 positive as of about 24 hours ago. And so our prayers are with them for a complete recovery. Now, technically, all we know is that they are SARS-CoV-2 positive. They do not have COVID-19. It's a minor semantic, but COVID-19, for everybody out there, that's what you have when you have a problem from the virus. But if you just own the virus, are infected by the virus, but it doesn't cause any problems, you just have a viral infection. And so we hope it stays just as a simple SARS-CoV-2 infection and doesn't go to significant COVID-19. Worldwide, President Trump and Melania join over 34 million individuals who have been infected by SARS-CoV-2 to date, 7.3 million in the United States. In Dr. Viskin's country of Israel, there are 259,000 cases. In my backyard here at Mayo Clinic in Rochester, we have 2,600 cases. Worldwide, there's been over 1 million deaths. In the United States, earlier, about a week ago, we crossed 200,000 deaths. In Israel, there have been over 1,600 deaths. And in our county here, where Mayo Clinic resides in Minnesota, 28 deaths. So thankfully, the case fatality rate, the death rate, as many of you know, is dropped. It's about 1 to 1.5%, all things considered. And we certainly hope that this infection in our president is nothing. My prayers are certainly with him and the First Lady, and I think all of you could join us in that. For those joining online, welcome. I see some of the familiar names and faces, and I can picture you. Glad to have you from Virginia, from the Netherlands, wherever you are. With our President and the First Lady having the virus, it's a reminder for all of us, put on the mask. The mask works. I mask, you mask, we all mask together. Respect this virus. Don't fear it. Respect it. Wash your hands. Stay 6 feet away when you can. Do all the things that can work. That's the COVID-19 update. But now, the next 37 minutes is for what I really want to do, is visit with Dr. Sami Viskin. Sami has been one of our just standard bearers of the Scientific Advisory Board for the SAD Foundation for many, many years now. He is faithful, a friend, and his guidance and advice and input has been critical to the success of our mission at SAD. So I want Facebook Live land to get familiar with my dear friend Sami. So Dr. Viskin, why don't you give our audience who's with us live now, and there's probably 50 to 100 who have joined us live, and there will be over 1,000 who will watch this video when it's posted and archived, give them a sense of who Sami Viskin is anyway. Thanks, Sami.
Okay, thanks, Mike. Just before I talk about myself, just one brief story. A month ago, we were performing an ablation procedure that it took a while, and one of the nurses was coughing during the entire procedure. So Dr. Rosa, who works with me, yells at the nurse and says, "Why are you coughing? Do you have the coronavirus? What's your cough?" Now, sure enough, he had it. He was positive.
Oh my goodness.
But since we performed the procedure all wearing masks. No one in the room, none of the doctors, not the patient, we were all wearing masks. Nobody got infected. So the masks do work. They work very well.
Put them on.
Okay, so thanks for having me here. My name is Sami Viskin. I work at Tel Aviv Medical Center in Israel. I spend my time working with arrhythmias, with all the channelopathies. From the academic point of view, I'm associate editor of Circulation. I was previously associate editor. I started in Europace, and then I moved to Heart Rhythm, and then I was recruited to Circulation, and that's where I spend a lot of time. That comes with a price. I spend so much time reading papers submitted to Circulation that I cannot say I'm really up to date with entire literature that is being published somewhere else. And when we'll be talking about papers published, I will have to put emphasis on papers published in Circulation, not only because it's the best journal, but also because it's the journal that I'm familiar with.
And we started with that, Sami. So our audience doesn't know, but one of the things we're hoping to do is quarterly have a video conversation with you about the highlight reel of impactful papers that are relevant to our families and their genetic heart condition, mostly the channelopathies, long QT and Brugada, and the cardiomyopathies of sudden death predisposing genetic heart diseases. And you heard Dr. Visken mention Circulation. Many out there don't know, but there are over 100 cardiology journals. Of the cardiology journals, always top in space, top 3 is the journal Circulation from the American Heart Association. It's one of the highest impact factor journals, usually competes with European Heart Journal and Circulation for the top 1 or 2 spot. And so I don't expect Sami to update us about what's excited him with genetic heart related papers in all journals, but he's going to have the focus with his role as associate editor of one of the top journals in the world in cardiology. And so with that in mind, Sami, why don't you share with us, we're going to see how many we can get through in the next 30 minutes, but why don't you start with whatever article from the recent past, whether it's circa January 2020, you can even go a little bit before that if you wanted to, but share with SADS Facebook Live your first paper that you think has been particularly interesting or impactful or bogus, depending on, but of course, nothing bogus gets published in Circulation. No fake news in that journal.
Yes. Okay, so 2 related papers that come to mind are 2 papers dealing with the reappraisal of the genes that are considered to be disease-causing, first in Brugada syndrome and then in long QT. So starting with the Brugada, I mean, there have been tons of publications about 21 genes that have been blamed or accused of causing Brugada syndrome. So you had a group of genetic experts who sat down for several months and re-evaluated the evidence for each one of these 21 genes to see, I mean, what is the weight of the evidence that we can say this gene is responsible for the disease. And they concluded that out of 21 genes, 20 were released for lack of evidence. Let's say if you're on trial, so there's lack of evidence that you were sent home again and you're no longer guilty, you're free to go, and only one, the CF5A gene, was the only one that remained as disease-causing. And a second paper did the same thing for long QT syndrome. Out of a number of genes, only the main 3 genes remain as the true culprit causing genes of long QT. And this is very important because especially for Brugada, there are too many patients who were diagnosed where the genetic diagnosis had a lot of impact. And this reminds us that how important it is to first make a clinical diagnosis based on the phenotype, based on the clinical symptoms, based on the electrocardiogram, before you even start fishing around for the genetic testing, and not the other way around. In Israel, for example, we use a lot of quinidine to treat Brugada syndrome. So I get a lot of emails from patients who have been implanted with ICDs because of Brugada syndrome. And then they ask me, and then they get infections from the ICD. So then they write me to ask if they can stay without the ICD then now that it has been explanted and just move to quinidine therapy. So I ask, send me what's your diagnosis being made of? And it's always a lot about genetics. And many of these patients, I have to tell them, I'm not even sure you have the disease. So this is a very good reminder that the diagnosis has to be based on the phenotype, on the clinical diagnosis, and confirmed only with the genetic test and not the other way around, where you have to be careful. So when it comes to genes, it's a pendulum. So I'm sure that some of the genes that are now back in the closet will come back with new evidence, and we'll have to stay open to that. But it's a very good reminder that the phenotype, the clinical diagnosis comes first, and it has to be confirmed by genetics and not the other way around.
Yes, Sami, I think those are really important. Full disclosure out there, I did not have anything to do with the articles that Sami chose. Both of those articles I co-authored. We like these two papers a lot. They were led by Dr. Michael Golub out of Canada, and Sami and our mutual dear friend Arthur Wilda joined me on this effort as well. And I think one of the things that is sobering from that exercise is that a lot of us know, Sami, about a place that I've called genetic purgatory, and the variant of uncertain significance issue within the known genes, the irrefutable genes, so the VUSs, and now we have to add to purgatory the GUSs, the genes of uncertain significance. And I liked how you said that it needs to drive people back to what's the strength of the evidence in the first place. So a lot of times the families have said, so now what do I do? I'm told that I have Brugada syndrome because I have a gene for Brugada syndrome subtype 17 or whatever that gene name. And I think you nailed it, right? You said, tell your cardiologist to ignore that genetic test result altogether and say, do you still think I have Brugada syndrome regardless of what the genetic test said?
And this is very true. It's true for long QT, and I'll come back to that, but it's very true for Brugada because nowadays, when you look at the series of patients who receive implantable defibrillators in Europe for the diagnosis of Brugada syndrome, the majority have no symptoms and were diagnosed by having a positive challenge test with one of the drugs that we use to unmask the Brugada syndrome, flecainide or ashmalin or procainamide. And I keep saying that, the dogma is that the test is 100% positive, and I'm sure it's not true. And there are several publications that are false positive with the test. So you can have a false positive test and then a genetic test that is in one of these genes, and you can end up with the diagnosis of a disease that you might not necessarily have.
Yeah. And Orla, thanks for the question. Orla Sami is asking, what gene was mentioned for Brugada as being significant? And for Orla, of all of the 21 genes that were on the original hit list, only one has stood the test of time, and it was the first gene, the gene SCN5A. Now, Sami, what do you think we should do? So after our papers came out, we had some of the discoverers of the other genes being rather upset So Dr. Barry London, for example, great guy. He discovered GPD1L Brugada, which is really Brugada 2 gene. The evidence was pretty convincing, and my reaction to all of us, because some of my genes that my team discovered got on the demoted list of refuted evidence, limited evidence, and I view it as kind of, roll up your sleeves, game on. If you really think that gene is a disease gene for that disease, Brugada long QT, assemble stronger evidence. What do you think should be the counter challenge out there for those discoverers who now find their gene on the demoted list?
Okay, so first of all, I'm not the judge. The editor is not the judge. I mean, we as editors, we send the papers to experts and we ask them to evaluate, and then we read the opinions, and if they make sense, then we go with them. I'm not a genetics expert, certainly not as expert as you are. So I am in no position of deciding which one of the genes is correct or not. I mean, we get the paper, we read the paper, it makes sense, we send it out for expert reviewers, and we get the comments back, and then we make decisions, but we trust our government. It's not really our call.
Yeah, and I think there's no doubt that some of the genes got sort of thrown out as limited evidence. Like you said, they're going to get put back in time as we learn more and as we prove more. Like with long QT syndrome, we have the big 3 genes. They stood the test of time, but some of the minor genes also got labeled with absolute definitive, the genes that encode calmodulin. For calmodulin long QT syndrome that Peter Schwartz and his team discovered calmodulin 1 and 2, and then my team discovered calmodulin 3. Even though those are minor genes, they're definite ones, and so there's going to be a pendulum swing, like you said, where if that gene got on the demoted list, time for people to either accept that verdict or mount the counteroffensive to say, wait, it looks like I need to assemble more evidence to convince everybody, and so be it. Let's do it, kind of thing.
Yeah, but at the end, the message today is be careful. Do not accept genetic like it's gospel. Many people think if it's genetics, it must be true. I mean, it's in your DNA. What can be wrong about that? So it's not gospel, and it's a test, and you have to be careful with the test. And it's going to be a pendulum. Many of them are going to come back, and you have to reassess every single family, every single member, what the phenotype is, the clinical evidence. Does it correlate with the genetic evidence, and move off from there?
Yeah, I think that's great. I think people need to know that genetic testing is like every test we have in cardiology. It's imperfect, and there are false positives, there are false negatives, and people who forget that, pay the price. And worse, our patients and their families pay the price with overdiagnosis or misdiagnosis, and then overtreatment or incorrect treatment. So you've started us off with 2 great papers. Great, okay. Important papers, controversial. What's your third one, Sami?
The third one is one by the group of Connie Bezina. It's a multi-center study. You are a co-author there again. All the who is who in long QT syndrome is an author there in that paper. And one of our problems as editor was to get a good reviewer that is not in the author list.
Yeah.
So anyway, this is a paper looking at the topic of phenotype positive, genotype negative long QT syndrome. So these are patients who physicians very experienced, like yourself, like Arthur Wilde, like Peter Schwartz in Europe, very experienced, say, this patient has a clinical diagnosis of long QT syndrome. They send a genetic test, and the test comes out negative for all the genes that we know. So it's a very hot topic, and it's 11%. I mean, it's not such a small deal. It's 11% of all the patients who have a bona fide diagnosis of long QT syndrome have a negative genetic test. So what they did is look at the entire exome and compare it with the whole exome of the healthy population, and looked at a genetic variants. And they come back with a fascinating finding that many of these patients do not have one gene that is a disease causing, but they have minor variations in different genes. Not one of them is severe enough to cause by a disease in itself, but when they're grouped together, they work as a risk factor that increases your probability of having a diagnosis of long QT syndrome when you compare it to the healthy population. So it's a mix of several genes that none of them is good enough. And the findings is fascinating, because these patients with the phenotype positive, genotype negative, usually, I mean, they have symptoms and they have arrhythmias. The phenotype is severe enough as just as bad as those with genetic positive. Their family history is usually negative because they get a different combination of genes. So I thought it was fascinating. So we accepted right away, even with an editorial. And I'm sure you have more to add about this, because you know more on this than me.
Well, I think a couple of observations. We're delighted that circulation felt the way we did, and really a tribute and a shout out to Connie, like you said, the senior author Connie Bazina in Amsterdam, phenomenal scientist, assembled a true multi-international team. Samples came from all over the world to get to this new truth. And it really builds on another paper of hers in Brugada Syndrome, and even there, like you said, we can explain 80 to 90% of long QT with a monogenetic test result, like you said, gene positive. We have in long QT a 10 to 20% remnant, 11% in the paper, where there was no genetic insult identified in the known genes. And so now we have advanced this idea of 80% plus of long QT is monogenetic. One hit is enough. Now this work extends for the rest, the notion of oligogenetic, or several, or if there's many, this sort of polygenetic architecture that can collectively create a genetic cocktail that compromises what Dan Roden called your repolarization reserve to set you up. And I think Dr. Visken pointed out something that caught all of our attention a long time ago, which is in this remnant of gene negative people, there's virtually never a family history. And that's exactly the reason that Sami has pointed out. And my own PhD student, Carrie Turkowski, who just defended her PhD, we took it a step further then and said, are those polygenetic cocktail elements that seem to make somebody long QT when the primary test is negative, might those same elements make somebody who has LQT1, LQT2, or LQT3 a worse version? So if you are LQT1 and you have the cocktail, is that worse than if you are LQT1 without those genetic nudges? And time will tell whether or not we ever see a polygenic risk score added to the primary genetic test. I think for families out there, that's a stay tuned, because we have to determine, is it clinically important to identify that nudge, or was this mostly right now an academic discovery whereby the new elements of the cocktail might point us to new pathways that we had never thought about having an impact on the control of the heart's recharging system. And so I think we haven't seen, and there's other areas, right, Sami, in other coronary artery disease where they're starting to add the polygenic risk score. Whether we're going to see the polygenic risk score added to the long QT test or added to the Brugada test, I think that's a stay tuned, time will tell. What do you think? Do you think we're going to see that added, or do you think it's too early to know whether the contribution of that genetic cocktail was strong enough to potentially add clinically to the next generation of the genetic testing?
Well, I know of one group that is already looking at that in Brugada, and I hope you'll send your paper to us, because it really sounds. I think that's the way to go. I think that's going to prove okay. I mean, that's going to prove valid. Makes a lot of sense.
Yeah. Well, we have 15 minutes on our clock left already. We're flying through. We've done 3 so far, and Sami's going to surprise me and the rest of us with his 4th pick.
Okay, so my last one is a fabulous paper by Peter Schwartz. I mean, Peter Schwartz has been investigating and teaching us about long QT syndrome forever. Now, it is about long QT in athletes. Now, you have to understand that, Peter Schwartz is in Italy, and in Italy, it is mandatory to do pre-participation ECG screening to all athletes. If you want to compete, if you want to train, you have to do a ECG test. So they found like 300 athletes who have a long QT. So they are referred to the center of Peter Schwartz because he's a center of excellence in Milan. They're referred with a diagnosis of rule out or rule in long QT syndrome. So the first finding is that 1/3 of them do not have a long QT. I mean, this sounds like a lot, but you yourself have published on the overdiagnosis of long QT syndrome. Our group published before on the underdiagnosis of long QT syndrome, how bad physicians are looking at the ECG and deciding if it's the QT is normal or prolonged. So 1/3 of them end up not having the disease at all. From the 2/3, then, like another third end up having a positive genetic testing. So, okay, that's fine. But then they're left with an interesting group of long QT, a very long QT, a very abnormal QT, who have a normal, a negative genetic test. So you can say these are phenotype positive, genotype negative patients, end of story. But the issue is that they disqualified all these athletes so they stopped training, and then they called them for follow-up a few months later, and then they discovered that a lot of them, their QT had normalized a lot. So they come out with this very interesting theory that some athletes during training, for whatever reason, either genetic background, they develop a very long QT, but once they stop training, everything goes back to normal. So it's a kind of an acquired long QT, just like you get it from drugs. Like you can go to the pharmacy, buy a QT prolonging drug, start taking, and you develop a long QT syndrome. You stop the drug, the QT goes back to normal. So something is very similar. So it's really fascinating, and interesting enough, this came when I was. And sure enough, none of these athletes have a positive family history. So it really adds value to the observation that this is caused by training. The Peter paper came to me when I was studying an athlete in Israel. Mandatory ECG screening is also mandatory in Israel. So I was referred to a young girl with an athlete with a very low QT. She had a QT see in the above the 97th percentile of normal. She was clearly abnormal, and the test that we do, the quick standing test that we do to our patients, was extremely abnormal with G-wave morphology changes. Now, we do not disqualify athletes. We follow your work, Mike, that you show that patients with congenital long QT syndrome who are appropriately treated can continue training in a safe way. So we allowed her to continue competing with therapy. But then came the COVID-19 pandemic, and she was forced to stay at home for 4 months with zero training.
Wow.
When Peter's paper came to us, so we asked her, come, I want to see you again. And her QT had practically normalized. It's not entirely normal, but it's really very different. So I think Peter's observation has a lot of truth in there. It has to be confirmed by other groups and everything. And we have to do a more comprehensive genetic testing. Maybe they have the polygenic risk score after all. But I think it's a very, very interesting observation. I was fascinated by that paper.
Yeah, and I think our SADS Facebook Live land is getting a sneak preview, right? This is hot off the press.
Yeah.
And very interesting. And could I ask you, Sami, as you were telling the story of the detraining, it started to make me think about a disease we see in the SADS Foundation on the cardiomyopathy side, with arrhythmogenic cardiomyopathy, where training can create a form frust acquired version of ARVC, where certain types of training can train the heart to remodel the myocardium to look like ARVC. And so for people with ARVC, they know that those disease accelerator sports are things like triathlons, like long distance cycling, like long distance swimming, long distance running, high endurance training activities. And I'm just wondering, did they see any specific types of sports that were overrepresented in training or remodeling the repolarization system in a QT prolonging way?
No, not really. I mean, they do not really have that detailed information on the intensity of sports and the type of sports. That was one of the critiques of the paper. They do not really have that information.
Yeah. That would be interesting, wouldn't it, to know if there's a different type of training environment that flags the QT prolongers or moves them. And did they offer any kind of mechanism for?
Yes, they did.
Doing that? Yeah,
they did. Actually, I have, my own explanation is, if you take the long QT syndrome caused by AV block, the animal models of AV block, if you take any animal, any dog, and you ablate the AV node and you create AV block and you force the dog to stay with a very slow heart rhythm for several weeks, what you will see is the QRS will widen immediately after the AV block because you ablated the conduction system. Their heart rate will go down, but then will increase a little bit as the heart gets used to the new situation. But the QT interval will keep just getting longer and longer and longer and longer and longer, even though the heart rate remains the same. And when you look at what's happening at the cellular level, and you can see that they have downregulation of their potassium channels. So the dogs that have forced bradycardia, they create less potassium channels in the cell membrane, and therefore the QT prolongs. And you say, why should they do that? And one of the possible explanations is that, if you downregulate your potassium channels, you increase the duration of the action potential, then you will get more calcium coming into the cell. And you will be able to recruit more calcium to increase your contractility. So if you are a dog and you want to exercise and you want to increase your cardiac output, you cannot do it by increasing your heart rate. You have to increase your contractility. So how you do that, you increase your action potential by down regulating your potassium channel. So perhaps there's something similar here. I mean, this is just a speculation that it's a way of increasing a cardiac output in the athletes, and this is obviously pure speculation. There's no proof of that.
Yeah, but that's fascinating, right? To think that because I was trying to picture whether there would be an element of vagal tone. So those athletes who established a much higher vagal tone from their training regimen, whether that secondarily caused the repolarization reserve to be reduced in whatever way. But I like the idea of what you just offered. I think that's interesting. It'll be intriguing to try to unpack that going forward. And I think the important thing for the patient is, if you're an athlete and you're in an ECG screening program and your ECG gets pulled out of the pile saying flag for QT scrutiny, don't wave the white flag of surrender immediately and say, oh, I just have long QT syndrome, I'm done. I think this observation of Peter's puts a hard break on that and say, we have a lot of work to do now before we're going to sentence this person to a diagnosis of congenital long QT syndrome.
Yeah.
That's kind of encouraging news, because screening programs are only getting more and more. And the more we screen, the more we flag. And the challenge out there, and I'd be curious what you're doing, is it seems like with our screening programs, it's pretty easy to throw down the penalty flag. What I've observed is that once that penalty flag's been thrown down, whether it's thrown down on the QT interval or on bundle branch block or on whatever, there's a great reluctance to go under the hood and say, after further review, not enough evidence for said disease, we're picking up the penalty flag, you can go back and play.
Yeah, especially in countries like Israel, where there is not such a thing as shared decision. In Israel, by law, the doctor gives you the permit to exercise or sends you home. So if you allow somebody to compete, he's competing on your shoulders for the next 20 years.
Wow. Yeah, and that's a long time horizon to be interested in picking up that flag.
Yeah. Let me tell you, so, I was once involved in a malpractice suit about an athlete. It's a long story. At the end, I was innocent, but I was on trial for 17 years on a case on a malpractice suit, and I was coming back from the trial when a patient with mild hypertrophic cardiomyopathy who plays basketball came for his yearly checkup, to get his yearly permit to continue competing. So he goes into the exercise, says it's perfect, says, and I say, you cannot compete anymore. So he says, what happened? My condition got worse. So I said, no, my condition got worse.
Oh, no. Well, the one thing that you always have been is brutally honest with us as your colleagues and friends, and also your patients. And that's one of the many, many things that I have loved about you, Sami. And we've come to the top of the hour. And for those of you who've joined us live, I've been watching your questions come in, and there have been some really good ones. And we're going to archive these questions. And on one of the upcoming Fridays, when it's just me and you together, we will tackle some of these questions, because Summer, your last one was really good. And Jesse, yours is a great one. And I really wish we had time to address them, and we'll do that. But this one was really focused on giving you a chance to see through the eyes of one of the elite journal's associate editors what papers in our world of genetic heart disease are catching that journal's attention because of the impact that these findings are going to have or are having on your conditions for which the SADS Foundation is dedicated to. And Sami, I'm just going to give a shout out to you from, I'll just give the name Catherine. Catherine sends a thank you to you, Dr. Visken, for helping my daughter Emily's pacing make her safer with her LQT3 challenges years ago. Her EP consulted you, Dr. Visken, and it made a great difference in Emily's life. So on behalf of Emily and her family and the life-saving impact you had on their family, and on behalf of the SADS Foundation, Sami, and the impact you've had on families all over the world, thank you for who you are, for what you do. And I sure look forward to bringing you back in 3 months if you'll join us to give us the next set of picks as associate editor of American Heart Association's journal Circulation. Sami, thanks a lot.
Thank you, Mike.
And to all of you out there, until next Friday, stay safe, stay well, refuse to fear, respect the virus, stay coronavirus free for as long as you can, do all the right things, and we'll see you all next Friday. Take care, everyone.